Having me here today. As mentioned, I'm David Mirsky from the Children's Hospital of Colorado, and I'll be talking to you on pediatric neck emergencies. It's not advancing. There we go. So over the next 13 minutes-ish, I'm going to be providing a location approach to pediatric neck emergencies, specifically focusing on infections. We're going to be discussing ocular infection, nasal, periauricular, and then oral. So head and neck emergencies are a frequent cause of hospital visits in the pediatric timeframe, and most of these emergencies are going to be infectious in etiology. The clinical presentation is going to depend upon the location of involvement. So if it's an eye infection, you expect the child to come in with proptosis, orbital soft tissue swelling, and limited eye movement, pharyngitis, neck swelling, sore throat, difficulty speaking, and then otomastoiditis, periauricular soft tissue swelling. But these clinical manifestations can overlap, and we know we're dealing with children who are not the greatest historians. So sometimes it can be very difficult to know what you're dealing with, and imaging plays an important role. Understanding characteristic imaging findings and complications allows patients to be treated promptly and decrease hospitalization rates. As for what type of imaging you want to use when you're evaluating a patient, there's a lot of factors that should run through your head. First and foremost, you want an imaging modality that's going to best depict the pathology that you're looking for. But then you need to factor in what's accessible, cost, length of scans, need for sedation, as well as radiation. Radiography is tried and true technique. The indications mostly is for acute stridor or looking for radiopaque foreign bodies. Advantages is it's good at looking at the airway and it can identify foreign bodies, but the disadvantages is that it has low sensitivity and specificity for the majority of soft tissue processes that we want to identify. Ultrasound is great in the pediatric population, good at looking at superficial lesions like cysts, lymph nodes, or abscesses. It's portable, easily accessible, great at looking at vascularity of lesions, but the disadvantages is that it requires a high level of expertise in terms of the operator, and it's not great at looking at deep processes. What about cross-sectional imaging? CT is definitely the workhorse modality for looking at pediatric neck infections. Advantages is that it's rapid, it's highly accessible, great spatial resolution, great at looking at deep soft tissue structures. However, the disadvantages is that it's not great for soft tissue contrast resolution. So when you're trying to characterize, say, a mass or a congenital lesion, sometimes it's not that great. MRI is going to be good for complicated infection, osteomyelitis, soft tissue masses. It's got great tissue contrast resolution. It's good for looking for intracranial and intraspinal complications. But as we know, it's not readily available in most emergency departments. It takes a lot of time in terms of the exam time, and that thus may lead to sedation. So let's start with the orbit. Orbital infection is a common indication for imaging in the pediatric emergency setting. Superficial, uncomplicated infections constitute the majority of cases, and the majority of those can be treated on an outpatient basis, but if untreated or immunocompromised state, the prognosis can be severe. Bacteria is the most common causative organisms. We're thinking about the staph and the strep species, though in the immunocompromised, you can consider invasive fungal. So important when we're thinking about orbital infection is we need to determine, is this process preseptal or postseptal in location? And how we define that is the orbital septum, which is a fibrous connective tissue sheet that extends from the orbital periosteum to the tarsal plates of the eyelid, separating the periorbital soft tissues, which are preseptal, and the intraorbital or postseptal tissues, which are posterior to that septum. Then next, we could subdivide the postseptal complex into intra and extraconal, and the way we do that is we define the extraocular muscle beds. That defines the cone of the orbit. Everything external to that is going to be extraconal, and everything inside of that is going to be intraconal. So let's start with preseptal or periorbital cellulitis. This is an infection that's anterior to the septum. It's much more common than orbital cellulitis, occurring in up to 90 to 95% of cases, often due to local trauma such as a bug bite. Patients are going to present with unilateral eye pain, swelling, as well as erythema. And rarely do these lead to serious complications. The majority of these patients can be treated with oral antibiotics on an outpatient basis. Here's an axial contrast enhanced CT image where we can see that there's significant left periorbital soft tissue swelling without postseptal involvement. Here's how that looks on MRI, so very similar. I'm not encouraging you to use MRI for this etiology, but every now and then these slip through the cracks, and here's an example of such. What about postseptal orbital cellulitis? This is an infection that's posterior to the septum, and as I mentioned, can be subgrouped as intra or extraconal in location. This is most commonly due to sinusitis. Patients are going to present with worse symptoms than preseptal, so they're going to have fever, decreased eye movement, visual impairment, and oftentimes they will have a proptotic globe. And these are highly associated with complications, which leads to increased hospitalization stay and IV therapy. And as such, cross-sectional imaging is critical to define these complications. By far, of orbital cellulitis and sinusitis disease, the most common complication that we see is a subperiosteal abscess. These are most often medial, adjacent to the ethmoid air cells, or sometimes they can be superior in location, adjacent to the frontal sinus. They're best seen in the coronal plane as a lenticular rim enhancing collection closely opposed to the orbital wall. Here's an example of a superior collection intimately associated with the frontal sinuses, which are opacified. Superior ophthalmic vein thrombosis, while not that common of a complication, it is a serious one because it may lead to cavernous sinus thrombosis, which has a high rate of morbidity and sometimes mortality associated with it. On your left side, you could see an image of a child with significant left periorbital soft tissue swelling, really no significant postseptal involvement and no drainable collection. You could stop there and say, okay, left preseptal cellulitis, treat this as an outpatient, move on. But when you look at your image on the right, you can see where the yellow hour is, that there is a non-enhancing tubular appearing structure. You can use the contralateral side as your internal reference, and that's the superior ophthalmic vein that is thrombosed. And when you see that, you need to look back from there at the cavernous sinus, which is also non-enhancing, and this child has cavernous sinus thrombosis, something that we will come back to time and time again during this talk. But not everything is infection. In a child with a bulging eye, you could see lots of developmental lesions, such as congenital inclusion cysts, so benign appearing cystic lesions in and around the bony structures, sometimes teratomas in the newborn time period, so large lesions, proptosis, fat, calcium, those kind of things. We can see vascular malformations such as lymphatic malformation, which can have large cysts or microcystic. This is a microcystic variant. These should not demonstrate any solid or significant enhancement. Venous malformations are quite common in and around the head and neck region, so these enhance avidly following contrast administration and may show phleboliths within it, which is fairly specific for these lesions. Rhabdomyosarcoma, the great mimicker, these are aggressive appearing lesions and they do not respect boundaries. And then lastly, idiopathic orbital inflammation, which can really look like any of these processes because it can involve any part of the orbit. Let's shift gears to the paranasal sinuses. Acute rhinosinusitis represents inflammation of the mucosal lining of the sinuses. The most important thing to note is that this is a clinical diagnosis, not a radiologic diagnosis. Imaging can perhaps suggest the diagnosis, but it really needs to be put in the context of the clinical status of the patient. So the diagnosis clinically is sinonasal inflammation less than 12 weeks with sudden onset of symptoms. Viral sinusitis is by far the most common etiology, although you can have bacterial superinfection when you develop a sinus outflow tract blockage. While I mentioned imaging is not all that great for sinusitis, there are some features that can suggest it, but they are certainly not specific. And where imaging plays an important role is looking for complications of sinusitis. The best imaging sign that we do have on a CT exam is going to be that of the air fluid level, and even that is still rather nonspecific. With or without bubbly secretions, mucosal thickening. The most common location you're looking for sinusitis is going to be that of the ethmoids and maxillary sinuses. Often there's asymmetric sinus involvement, and pay close attention to the sinus volume, because if you have an opacified sinus that is perhaps enlarged, then you might be dealing with a mucocele, or rather small, and you might be dealing with chronic disease. In terms of complications of sinusitis, Popp's puffy tumor is by far one of the more common things that we see, especially a lot in Colorado. This is a misnomer. It's not a neoplastic process. It's a complication of sinusitis, specifically frontal osteomyelitis and subperiosteal abscesses. These occur in adolescence after the pneumatization of the frontal sinuses, and they have a high risk of intracranial complications in up to 75% of children. So we're looking for things like empyemas, abscesses of the brain, as well as cerebral sinus venous thrombosis. So on your image on your upper left, you can see where the yellow hour is. There's frontal sinus opacification, and overlying that within the scalp soft tissues, there's a subperiosteal collection. That's better defined in the image on the upper right, where you have a contrast-enhanced MRI image, and better defining that subperiosteal abscess, better defining your subdural or your extraaxial empyema, and then the green arrow is pointing at the bone, which is enhancing avidly, concerning for osteomyelitis. This is a variant of sinusitis that you do not want to miss. Invasive fungal is a rapidly progressive transmucosal infection that can involve any structure, vascular, bone, soft tissue, orbit, as well as intracranial invasion. Typically occurs in immunocompromised patients or severely diabetic children. Aspergillus is the most common etiology, though we do see mucormycosis from time to time. And the mortality rate is extremely high, so this is not a diagnosis you want to sit on. What you're looking for on imaging is sinus opacification with focal bone erosion, soft tissue where it's not supposed to be, so outside the lumen of the sinus, and non-enhancing mucosa. So on this image here, we could see non-specific mucoid material sitting with the left maxillary sinus. I don't know what to do with this other than to say it's there. I would not be suggesting fungal sinusitis just based on this appearance. But when you look at the retroantral fat and you compare it to the contralateral side, you can see that it is abnormal in signal on this fat-suppressed T2 weighted sequence. On post-contrast enhanced imaging, again, you can see there's infiltration of that retroantral fat extending into the pterygopalatine fossa. And more importantly is when you look at the turbinate, you're seeing complete lack of enhancement of the turbinate, the so-called black turbinate sign. We could see that in the coronal plane as well. But more importantly, you could see other findings that should make you concerned. Enhancement, intracranial or dural enhancement overlying the left orbit, as well as enhancement throughout the orbital soft tissues. All of these are very concerning findings that we're dealing with an aggressive infection. What's more disturbing is that when you look intracranially, you could see that this child did ultimately have evidence of intracranial infection. Here's a companion case. So on this sagittal T1 weighted image, we could see that the sphenoid sinus is filled with T1 hyperintense material. T1 hyperintense material is not all that specific. It can be seen in chronic inspissated mucoid material, but it can also be seen in the context of fungus. Here it is on the axial T2 weighted sequence showing significant lack of signal. So very, very dark mucoid material still. Maybe you could suggest that there's fungal elements, but you wouldn't be suggesting invasive fungal sinusitis until you come up higher and you look at the cavernous sinuses, and you can see that the cavernous sinuses are being infiltrated by fungal disease. So this is another case of cavernous sinus thrombosis. I told you this is an important area of real estate to look no matter what type of infection, and we're going to keep coming back to it over and over. Let's shift gears to temporal bone imaging. Acute otomastoiditis represents an acute infection of the middle and middle ear and mastoid air cells. Otitis media is the most common infection in kids under the age of 5, and it's initially viral in etiology. That said, superimposed bacterial infection can lead to mucosal swelling of the adductus and antrum, so basically the communication between the middle and the middle ear cavity and the mastoid air cells, resulting in trapped fluid within those mastoid air cells and then ultimately causing mastoiditis. This leads to bony resorption and demineralization due to intramastoid empyema. Clinically, these patients are going to present with fever, redness, and tenderness in the retroauricular location. Now, this is a classic scan that we get handed to us when they're saying rule out acute otomastoiditis. And what do I see is I see fluid layering within the mastoids and the middle ear cavity. I don't see any bony erosions. I don't see any soft tissue prominence. I don't know what to do with this. This is rather nonspecific. But then you look at this separate scan of a different child here, and now you start to see loss of the mastoid trabeculae, coalescence of air cells, and then deficiency of the over and underlying cortical structures, as well as soft tissue prominence. And now you're suggesting the diagnosis of acute otomastoiditis. There could be a variety of complications in AOM, specifically subperiosteal abscesses, which are usually not too hard to see if you're giving contrast. The Bezold abscess we hear often about in books. I wouldn't say in clinical practice it's all that common. It's basically rupture through the mastoid tip along the course of the sternocleidomastoid muscle. Intracranial extension is very common, specifically extraaxial empyemas, or oftentimes you could see intracranial abscesses, as in this case. And then lastly is venous sinus thrombosis is something you want to pay close attention to because we know that the transverse and sigmoid sinuses run closely to the petrous apex. This is an important one. The apical petrositis or petrous apicitis is an important complication of AOM. So it represents extension of otomastoiditis into a pneumatized petrous apex, resulting in petrositis. The classic triad of symptoms, so Gradinego syndrome, where you have otomastoiditis, deep facial pain, and then sixth nerve palsy, it doesn't occur all that often, so it's not all that helpful in a clinical standpoint. From an imaging aspect, you're looking for trabecular breakdown and cortical erosions with an opacified petrous apex. Evaluate those adjacent vascular structures for involvement, such as the ICA, the venous sinuses, as well as the cavernous sinus. So here you have an image, an axial T2 weighted image through the level of temporal bones, and we see that there is opacification of the mastoid air cells and middle ear cavities, not a very specific finding. There is opacification of the right petrous apex and a little bit of opacification on the left. But funny enough, when you look harder, you see that there's a little bit of right ocular proptosis and right orbital swelling, and that's a little odd to be seeing when we're considering otomastoiditis. We look at the flare sequence, and now we run our flare sequence following contrast administration. You start to see enhancement within the right IAC, as well as enhancement posterior to the clivus. And then more disturbing on your diffusion-weighted imaging, you could see that there's diffusion-restricting material throughout the mastoids, the miliary cavity, the petrous apex, and the cavernous sinuses. So this patient had cavernous sinus thrombosis, which led to inflammation of the IAC, showing narrowing on the right greater than on the left. And sadly, this child did ultimately have an infarct of the right thalamus. Finally, we'll land on tonsils. Tonsillitis represents acute non-suppurative tonsillar inflammation. It's a very common reason to go to the office visit by children. It's most commonly due to the respiratory virus, though about 30 to 40% can be bacterial, specifically group A strep. And what you're looking for on imaging is a striated enhancement pattern of the tonsils, or what's known as the tiger striped sign, and absence of a well-defined capsule. And then oftentimes you will see reactive adenopathy. Here's how it looks on MRI, very similar to what it looks like on CT. And again, I'm not recommending using MRI for this diagnosis, but every now and then we get that. What about tonsillar and peritonsillar abscesses? These are the most common location of head and neck abscesses in children and young adults. Tonsil abscesses represent a palatine tonsil when it separates with abscess formation. Here's a unilateral involvement on the right, and then here's bilateral involvement. Whereas peritonsillar abscess represents a tonsillar abscess that spreads to the adjacent parapharyngeal, masticator, or submandibular spaces. And it's important to denote that so that your surgeon is aware when they're going to treat these patients. Oftentimes you'll have reactive or bulky adenopathy in these patients. And speaking of adenopathy, tonsillitis is highly associated with, when seen with lymphadenopathy, is highly associated with Epstein-Barr virus or infectious mononucleosis. So it's a very common infection, often subclinical in childhood. And what we're looking for are things like tonsillitis, lymphadenopathy, and splenomegaly, as you can see here. I'm being told that we have very little time, so I'm just going to breeze through this case very quickly. This was a child that had tonsillectomy. You can see that there's abnormal bone in the operative bed, as well as widening of that spheno-occipital synchondrosis, abnormal enhancing tissue, abnormal signal within the cavernous sinuses, and this patient had cavernous sinus thrombosis from an adenoidectomy. And we had a comparable case come not too long after that. Again, abnormal infection along that operative site, cavernous sinus thrombosis, and so we ended up publishing this. So thank you. Imaging plays an important role in pediatric head and neck emergencies. Understanding your imaging findings and complications allows patients to be treated promptly, and don't forget to look at the cavernous sinuses. Thank you.